Can somebody shut the door, please? Thank you. Welcome, everyone. We're gonna talk about this topic, which was an interest of mine to go through what's in the literature, why some people believe it exists, and why some people say it's made up called the AKI, and why we should look for it if you don't find a reason, if you're blaming on the contrast. Okay. Alright. I have no disclosures, just my curiosity. And so we're just start with a short clinical case, just to set the mood for the topic. So here we have a 61-year-old female with histocirrhosis, alopecia varices and ascites. She initially presents with drug for breath, and it's pretty much why there's a pretty sizable infusion here. So she was admitted on the 19th with compensated cirrhosis with a pleural effusion. She underwent a paracentesis and also was started on liver transplant evaluation for the cirrhosis. Her course was complicated with AKI on the 30th, and she also had reaccumulation of her hydrothorax. Then days later, she was hypotensive, was later on found to have pneumonia, and she got contrast 3 times. On the 19th for a CTA when she came short of breath, on the 25th for a cardiac cath for liver transplant evaluation, and on the 29th for CT triple phase for the liver. And here we can see what happened to her creatinine when she initially came to the hospital. Baseline around 0.6. She got contrast here. Small bump in the creatinine, 0.6 to 0.8 roughly. Then she got contrast again here. Creatinine remained stable. And then she got contrast a 3rd time. And we can see how it exponentially rose after the 3rd dose of contrast here. And now we might be asking, well, how much did hypertension influence the AKI? This is about the time that she got the contrast here. And the creatinine rose. So she got contrast on the 29th, which is around here. And this when her creatinine started to go up. You can argue there's a blood pressure of overall downtrending, but there's no clear hypotensive insult here. This is her fever curve on the right side, and we can see it's pretty much stable, as well as the WBC count. Now, is it contrast-associated nephropathy? Is it not? Hopefully we'll have more insight after the presentation or not. We'll see. Okay, so why is it important? It adds morbidity to our patients, prolongs hospital stay and costs, if it's really a thing. And it precludes patients definitely from getting appropriate studies and interventions, whether it exists or not. People are more cautious about other contrast in these patients. They're at risk. So we'll understand the proposed pathophysiology, define some terms, interpret the epidemiologic data, what is available, and review some preventive strategies. But first, we'll go through a little bit of what I call really basic radiography physics from a nephrology fellow that doesn't really understand these things. But I was curious to see why we give iodine to patients, if it's possible risk, and I wanted to understand why we give iodine to patients and share this with you all. So basically here we have the accelerator, which is the X-ray machine. It's going to accelerate electrons. They're going to leave the cathode and go to the anode where they have tungsten. The collision of these electrons here is going to generate photons, which are going to be canalized through this window. They're going to go through a path to, I'm going to call tissue or matter. And they have a detector here, which is what we call also film. And it's going to cause some attenuation depending on the tissue. The CT scan is about the same process, but it's more complex and it goes around the patient in several different slices. What's going to cause the attenuation is basically 2 things, 2 interactions, the Compton scattering and photoelectric absorption. Now, Compton effect is something that you don't want to see in an X-ray because it's going to cause blurriness and haziness. It's when the X-ray, both the photon hits an electron in the outer shell of the anode, and it scatters the electron, and it releases a new wavelength, which it's not the same, that it's a different path, so it's gonna cause some haziness. The probability of this happening depends on density of the matter. So things that have lots of water, muscle, blood, they will have more probability of complex effect. And if we remember the first picture that I put, the radiograph, the patient with the pleural effusion, it kind of looks hazy. It's not like a clear cut. It's not like that, because it has a water. Now, photoelectric effect, something that we want to see, because that's going to bring contrast to the image, attenuation to the image. And it's a different process. It's the photon. It's going to hit the inner shell of the atom, and it's going to displace it. And then another electron is going to jump in to the inner shell, like the K shell, which is the first one, if you guys remember physics. I didn't, so I had to research. And that most of that energy is going to be absorbed. So the wavelength that leaves the atom, it doesn't really change the image. The energy is absorbed, so it's going to look white. Now, why iodine? Iodine has a high atomic number, and the higher the atomic number, more absorption is going to happen, more photoelectric effect is going to happen. Now, as the energy is released from the X-ray, it's we have a high scale here, depending on the tissue atomic number, and here it's saying around 7 will be the average for all tissues. As we increase the energy from the X-ray, the usual energy is around 33 of the photon energy, which is the one that we use for therapeutic and diagnostic purposes. As we increase the velocity of the electron, you would imagine like a fan is spinning. If you increase the energy too much, it's just gonna go, it's not gonna collide with anything, it's gonna look black. But for iodine, around the 33 mark here of what the energy that we use for X-ray, we actually have this increase in attenuation coefficient. So it's gonna look very white and sharp, and this is, what we want to see for contrast of the image and to identify structures. All right. So we established, okay, all right, let's continue to use iodine, seems, pretty good. Now the contrast media, we have two different types, water soluble and water insoluble. Water soluble, we can still divide for the osmolality of the media. Osmolality was the first one that was created, and now we actually fell out of favor. It was the first generation. It has osmolality of 5 to 8 times of the serum. And mostly it's used now for gastrointestinal use, cystorectal administration. So we'll leave that alone. For a low osmolality, we have osmolality of less than 3 times of the serum. And this is what we're recognizing here. Iohexol, omnipaque, we use this pretty consistently for intravascular contrast. And for isosmolality, so now this is a little bit of a misnomer. If you look here, low osmolality is less than 3 times. But isosmolality is actually lower osmolality, because it's the same as the serum. They call isosmolality. So it might be a little confusing, but that's how it's been named, because it was historical. And this one, actually, the other ones, they had triiodinated rings. This one is 2 covalently triiodinated rings. So we have higher concentration of iodine per osmol. So this is going to bring more opacification to the image with less osmolality. And we have here iodexanol, Visipaque, which we use here too. Water insoluble, we don't really use this. It's for amyloid sclerotherapy, so we're just going to skip. Now this is a comparison of all the different types of water soluble. And as I mentioned about the iodine, we have more iodine in the isosmolality here, and these are the differences in osmolality. So isosmolar is lower than low osmolality. All right, so now we're jumping into the pathophysiology.
Can I ask one question?
Sure.
Because this nobody clarifies ever. So there are more, so it's a larger molecule with more iodine, you see. So since there are more iodine in your physiology slide, you say that mass attenuation coefficient.
Mhm.
So does it provide eventually the same mass coefficient for as the high osmolar, considering that it has more iodine molecule? Like,
They didn't explain that. I would assume that, you have more iodine, but it's less osmolar, so they're probably making in a way that you're gonna have the same effect with less osmolality. So I don't know in terms of mass, I know the yield is the same, basically.
the photo looks the same,
Yeah,
like the contrast looks the same.
Yes.
Because this is a much larger one. Thank you.
Yeah, so they have more iodine. But it's still less osmolality when they
It's a
formulate.
larger molecule, correct?
Yeah, larger, but we have lots of hydroxide groups here. All right. So pathophysiology, so this all kind of hypothetical and how this interacts actually with clinical picture. And there are many different proposed pathophysiologies. So the most claimed ones that I'm gonna bring here, direct cytotoxicity, hypoxic renomedullary injury, reduced blood flow, and hyperviscosity and osmolality changes. Now, direct cytotoxicity, again, not fully understood. We know that as the contrast reaches the tubules in the kidneys, the water is absorbed, but the contrast itself, it's not absorbed. So it's going to be super concentrated and with lots of viscosity. And it's going to linger in the tubules and have a lot of interaction with the cell membrane. And also create reactive oxygen species, which will be toxic to endothelial and tubular cells. So they found evidence of mitochondrial damage and plasma membrane damage. There's also proposed cell apoptosis from signaling pathways. And then at the end of this, necrotic tubular epithelial cells will also fall in the lumen and will cause obstruction, increasing pressure in the tubules, reducing glomerular filtration. And here it's kind of hard to see, but there are tiny vacuoles here that they can see in pathology slides. So this is suggested by evidence in changes in cell injury when they do pathology in subjects, either animal models or people. And also the evidence of enzyme after the contrast is administered. They also put in cell cultures and they saw renal tubular cell injury. And animal models will show the same vascularization. However, when they did the studies, it did not necessarily correlate to change in renal function. So they will see the changes, but renal function is going to be pretty much the same. And sometimes you have dysfunction, and then when they do all the pathology and all the studies, they don't really see morphologic changes. So it's very controversial. So will be my conclusion here. The tubular anatomic findings, they rather represent exposure than necessarily injury. So, but this is, what's the proposed mechanism for direct cytotoxicity. Now, hypoxic medullary injury, they really wanted to know why. They put probes in animal models to check the partial pressure of oxygen in the medulla and see how the contrast affects it. So actually decreases, we already work with the medullary oxygen pressure, it's already lower than the rest of the body. When you give the contrast, it lowers even further. It is a different osmolality contrast. So it does reduce the oxygenation of the medulla. And surprisingly, when you give furosemide, because you blocking the NKCC2 co-transporter, you decrease the utilization of the oxygen, and you actually increase the oxygen level. We'll briefly touch base about furosemide later, because you would think, okay, so let's get furosemide, person's getting contrast. No. Okay, we'll get to that later. So, it's been proven that it decreases the oxygenation, and obviously we are changing the factors that will maintain the oxygen offer the supply and the utilization. So that leads that the patients are prone to ATN. We also have impairment of intrarenal hemodynamics, and some of these mechanisms, they kind of, blend in some points. We'll have the reactive oxygen species is a big thing here. That's caused by the contrast, will cause tubular glomerular feedback, will lead some hyperperfusion, and also this specific oxygen species, the superoxide, will also decrease the bioavailability of the nitric oxide in the thick ascending limb. And stimulate the absorption of sodium chloride in the tubular segment. So this will decrease perfusion. And also the lack of nitric oxide, you have more vasoconstriction and endothelial cell dysfunction. And at last, for the pathophysiology, we have hyperviscosity and hyperosmolality. It contributes to more obstruction, besides the cells dying off and also blocking, which will lead to further apoptosis and necrosis. And in the blood, it can also, well, they say, it might cause some microvascular thrombosis and decrease of the plasticity of the red cells. So we have less offer of oxygen. This is basically what we discussed. We have effects in the epithelial cells, endothelial cells. We have apoptosis, endothelial dysfunction, and at the end, hypoxia, ischemia, tubular necrosis, and acute kidney injury. Okay. Now definition. Historically, we still sometimes say contrast-induced nephropathy, which used to be, it's still defined for those who believe in it, an increase of creatinine 0.5 or at least 25% increase from baseline creatinine, and not here exactly, but also a decrease into 25% of GFR 48 to 72 hours after exposure. But because now it's known after the initial studies that were done in 1980s, 1990s, 1970s, some of them, it's been noticed that patients that are hospitalized, there is a lot of variation in the kidney function. And so because some of these factors might be interfering and variation will happen regardless of patient getting contrast, now it has gained favor to call contrast-associated AKI or contrast-associated nephropathy. Clinical features, this is based, so this review articles will describe this, and then when you see what's the source, it's studies done in 1980. So this is based on the previous initial epidemiological studies. They will say clinical feature is going to show an acute rise after the contrast was given 24 to 48 hours later. It usually takes 3 to 5 days, returns to baseline in 7 to 10 days. Non-liguric most of the times. Sometimes you can see granular cast tubular epithelial cells, or it can be either it can be blend, and we very commonly see the high specific gravity, and some patients will also have low FeNA. All right, so now we're gonna try to understand what's out there in terms of epidemiology. So I'll start with this study. This is not a control study. It was just done in the VA to see what's the incidence and outcomes in contrast-induced nephropathy. And it was done in different modalities of contrast study. It's the VA, so we have 11,000 patients initially being screened. We ended up with 585. Most of the patients, they got isosmolar. So the minority of them got low osmolality. So this is what we can see here, the different groups, CT, coronary angiography, and non-coronary angiography. And we can see that non-coronary angiography actually is the one that had more incidence of AKI. And I'm highlighting here all the criteria for diagnosis that was statistically significant. Okay. Another study, no control, this one again, showing the incidence and predictors of outcomes of AKI in patients undergoing PCI. So now we're looking only for PCI. And this is a pretty sizable study too. We ended up with close to 1 million patients. This is the National CAS PCI registry. So everybody having a CAC basically here. And we can see here, any AKI was only 7.1%. And obviously, we are accounting for AKI for any other reasons, it's just incidence of AKI in patients going this study. AKI in stage 1, 6%. And here the analysis look tiny 0.3%. And here now we're gonna see the stratified analysis based on the characteristic of the patients. So we want to see dialysis. Just a small increase in creatinine is not going to be that significant. So when we look at dialysis, we see here which ones were the most common characteristics in the patients needing dialysis. And I highlighted here the higher numbers here. And the higher incidence, 62% of patients with diabetes, the patients had diabetes, 86 hypertension, dyslipidemia, and severe AKI. So severe CKD, which is stage 4 and 5. So we may say these are likely the conditions that will make patients more prone for AKI after contrasted study. Okay, so now this one, we're gonna look at a control study. And why I'm bringing this study here is because looking through the review articles, I could see recommendations and conclusions based on these studies, and this is actually used by KDIGO when they address the subject to say whatever we're gonna see now. So this was a retrospective comparison. Incidence of AKI patients going CT. So now we're looking at CT with contrast and CT without contrast. These are the baseline demographics, and very early on we encounter a problem here. We have a control, we have iodixonol, which is isosmolar, and iohexol, which is low osmolar. So this one. And looking down here, we can see that control group actually had more patients with severe kidney disease, chronic kidney disease, comparing to the other groups. It's double the number of patients getting the isosmolar contrast, and a lot more than the patients getting the other contrast. So looking to this bar graph here in the top, we can see here the incidence of AKI and the baseline creatinine concentration. Not really a lot of difference in the lower spectrum of the creatinine. As we reach here 1.9 to 2.0, we can see that our hexol, our low osmolality contrast, is actually causing more incidence of AKI. And same here, above 2 of creatinine. Showing that our dixonol and control actually had similar incidence. However, when we look at the numbers that are statistically significant, we can see our hexol, yes, it does have some significance here, both in the aggregate, all patients, all different types of severity of CKD, and patients in stage 3. Okay, we can see there's a tendency of more correlation. I should rather say, of AKI happening more in these patients. But for iodixonol, we don't really have statistical significance over here. And again, as I said, physicians are much more likely to order contrast CT without contrast if patients have more risk for AKI or they have severe CKD. So again, this is what we're going to get with all retrospective studies. We're going to have this selection bias. Now this study here, it's to show the incidence of AKI in patients going imaging with IV contrast and no IV contrast. This is actually a meta-analysis. So they started with 1,400 studies and ended up with 13. Most of them were retrospective. And here we can see the incidence when they compared all the patients from the meta-analysis. Actually, control study control group of patients had more AKI. It was 6.5% of patients having AKI compared to patients that got contrast was only 6.4. Okay, is contrast protective? Of course not. This is selection bias. They don't give contrast. So, and we can see the same thing here in the forest plot. So, this is basically my conclusion. It's physicians are likely to avoid, outdated contrast media in patients at high risk for AKI, like advanced CKD or sicker patients. So the sicker patients will get, this study without contrast, they'll have AKI for other reasons, and then we don't have good results. Now we're gonna look at the incidence following PCI. This is primary PCI, and control group that had STEMI and did not get conservative management, or they got thrombolysis. So on the STEMI PCI cohort, we have 2,000 patients against 1,000 patients going for thrombolysis in overperfusion cohort. And we can see the PCI patients, 10% had AKI compared to the thrombolytic therapy, 12.1% developed AKI. Slight difference in the baseline creatinine. Thrombolysis had slightly higher creatinine concentrations at baseline, but the slope is similar. And we can see that both lines here in the receiver-operator curve is the same. So again, patients not treated with PCI, they had more risk factors for AKI. And this is, this study put that out, that they had worse baseline, slightly worse baseline creatinine, older age, and higher rates of KILIP. I don't think we use that anymore, but KILIP plus 2 and 3 for patients with STEMI. Okay. Now this article from Jason, it's going to show the burden of AKI among patients receiving radiocontrast comparing with patients that did not get radiocontrast during hospitalization. We have a pretty sizable sample here. 5 million. They really want to know. And there's actually no difference when we look at all subjects. So this, the dot is no contrast, the cross is yes. And maybe pancreatitis, we had more patients having AKI. This is the incidence of AKI. Oops, sorry, incidence of AKI. And there's really no difference, but we come down to the same point. And why I'm showing all this, studies to you all, it's basically when I went through all the review articles and, expert opinions about is what's the incidence, what's the real incidence after, newer studies came out. These are the kind of evidence and data that they analyze to actually say, well, there's no CAN, there's no contrast associated nephropathy. This is basically what's out there. So welcome to my frustration. This was my conclusion, part 1. We need to interpret studies with caution. Obviously, what comes to light now is the incidence is not as close to what they used to say. So older studies, they will say it's the 3rd most common cause of AKI in hospitalized patients. So it doesn't seem to be nearly close to that. So, but it's the data that is out there insufficient to declare that, they're not nephrotoxic. And another thing is when we are assessing patients, whether, it should be okay to give them contrast or not, the risk for renal replacement therapy is very, very infrequent. And that one of the initial studies, it was 0.3% of patients going for CAF. Okay, so what are the preventive strategies? Okay, furosemide. Can we give furosemide to patients going, will improve the oxygenation in the thiccocerebellar limb, the loop of Henle, in the medullary part of it. They actually tried it. Obviously, they gave fluid with it because they didn't want the patients to be vomiting. They didn't have an AKI for that. And they compared not only furosemide in saline, but mannitol in saline and saline. And basically, there was more AKI So this here, 28%, 40, and 11% patients getting CLE. We didn't have a lot of patients here, but this at the time was like a landmark study published in 1994. Okay, so no furosemide, no mannitol. Now bicarbonate. Bicarbonate, it's thought to cause less reactive species of oxygen when it's in the when it's given before the contrast. And here we also see bicarbonate in acetylcysteine. They compare bicarbonate with sodium chloride and acetylcysteine with placebo. And basically, if you guys can see, forgive me for the low, the small font, but this is 4.4, 4.7. It's across the board. It's the same instance of AKI, which the primary endpoint was AKI. So doesn't seem to be better than saline. So no bicarbonate, no N-acetylcysteine. And now statins. This was something new to me. I was not familiar with studies about giving statins to patients going for contrast. They studied this a lot. So most of the studies were done for patients going for PCI. And these patients typically, they are put on high intensity statins for obvious reasons. But when they compared low statins and high intensity statins, these patients actually had less AKI, but it's a little unclear why. So there are some trials with small size of patients. They actually will say, okay, statins, they are good. But another trial that I found here, the PROMISE trial, which is also mentioned in many review studies and had decent statistics, actually showed no difference. So, and these were done for patients going for BCI. I didn't see any studies for patients just going for CT scan or other types of angiography. So it's kind of like a moot point here. We're going to give statins anyway for patients that, they have sting or whatever reason it is that they're going for cardiac cath. So for our purposes here, pre-treating patients that are going to go for contrast studies, I don't think you're going to be putting patients on high dose rosuvastatin before they go for, a CT removal. So now we come to hydration. So basically, we're coming to the end of this topic. We have this study from Lancet, which was the amazing trial. They looked in patients with a moderate chronic kidney disease, stage 3, prophylactic hydration prior to contrast. So we'll take a look at the study. We see here 300, there was a randomized control trial. They allocated patients to the H+, which is the hydration group, and they had 2 different protocols. They had the short protocol, which is 4 hours prior and 4 hours after, which was 3 cc's per kg per hour of IV fluids. And the longer protocol, which was 1 cc per kg per hour, 12 hours prior and 12 hours later. And the H- group was no hydration. They just didn't do anything. And this was a non-inferiority trial. So just want to see, well, is it the same thing just to do nothing? And well, surprise, surprise, you're already looking at the forest plot and you can see it was non-inferior. So in the population, we can see the incidence was actually similar in the H+ and the H- group. Here, 2.6 against 2.7%. The caveat here is this was mostly done for, there was a lot of CT scans, not for intraarterial procedures, which are thought to have more risk for AKI. And it was only for moderate chronic kidney disease. So they didn't do this special CKD stage 4 and 5. Oh yeah, this is what I want to show. And most of the patients actually, that was CKD3A. This is 2/3 of the patient approximately. They actually had CKD3A. So they are at risk compared to population with no CKD, but it's lower risk compared to the whole CKD population. And now the last trial we're going to look this afternoon here was this, from Lancet. They also look for patients with a GFR less than 60. And this is only for cardiac cath. So now they're, raising the stakes here. These patients actually have higher risk. And they guided the hydration protocol by the left ventricular and diastolic pressure. If anyone was falling asleep, I think they woke up now. So we have here 196 patients included in the trial and 200 that were randomized. This is the protocol. So all of them got a bolus infusion, 3 cc's per kg for 1 hour. So it's a shorter protocol, which makes it more convenient. And then they put a catheter in. They check the left and diastolic pressure, left ventricular diastolic pressure. 5 cc's per kg if it was normal. Normal is it's below 12. It's up to 12. So if it's normal, they gave 5 cc's per kg for 4 hours. If it was moderate elevated, they gave 3 cc's per kg. And if it was still, kind of high here, 18, they still gave 1.5 cc's per kg. And the control group got the same for the higher left ventricular diastolic pressure. And all of them continued for 4 hours. So it was a total of 5 hours of IV hydration. So we can see here the average LV-EDP was 12 on both groups. And most of the patients, they were here less than 13. And here is the mean GFR for both groups was 48. And they had similar creatinine concentrations. This on the top here, we can see how much fluid the patients got. An average here around 1.8 liters for the patients getting an intervention, and for the control group of around 900 cc's. Now the primary endpoint was the occurrence of AKI. And we can see here, the guided group had less AKI compared to the control group, and this was a significant difference. And when we look at all-cause mortality, it was also a better profile. So I don't know why the quick control should be red and the hydration should be blue, right? They made me confused when I was looking at this. It's like, wait, what? Actually, so the control group had more complications, which was all-cause mortality, myocardial infarction, or dialysis. And then you were probably asking yourself, what happened? So did anyone, need diuretics afterwards? What happened? Actually, the same number of patients in both groups needed to stop infusion. So it was 6 patients in each group. And 1 patient in each group also needed diuretics. So I would say not bad at all. And it was easily managed. So coming to my second conclusion, and this is going to be the final conclusion for today, is IV hydration might have a protective effect. We have 2 good trials that have different conclusions, but it might be protective, especially in patients going for intra-arterial procedures, such as PCI. Fluid rich should be individualized, so we can write up prescriptions depending on what we're seeing at the bedside. And shorter protocols, they do seem to be effective. The last study, the Poseidon study, actually was only 5 hours of IV hydration. So, and compared to the control group, it was actually efficient. Any questions?
Slides back.
Oh, sorry.
In the back, 2 slides.
Anyone
Yeah,
needs this
sorry.
still? No?
It's too tiny.
Sorry, I'll make it smaller. Camera. This is the size that it comes. I'm not sure if I blow it up.
Can you use your camera and do metrics? I can your old phone.
Did it work? I'm gonna end up with. I don't want anyone to be sad, okay?
Okay, I'm just gonna do it.
Okay.
Maybe did it. Oh.
Is that better?
Yeah, I mean, the mirror did it.
It's not, okay, all right, we'll go 2 slides back. This
Yeah.
one?
So when did they measure the creatinine there? What was the time period? Like if they give fluid, are they measuring like in 2-3 hours or 5 hours, 6 hours? Where
They-
there is a hemodilution and it has a dequilibrate?
To tell exactly what time they measured, I would have to look it up, but it was, they measured, they confirmed 48 hours after. What was the change? So what was reported was at least 48 hours. Some of the patients, and now I'm getting confused with all the studies that I read about creatinine being checked. But some of the studies, I'm not sure if this one, they allowed for creatinine to be measured a few days later for convenience, if the patient was getting discharged and couldn't get a creatinine repeat in 3 days. It was like over the weekend, they allowed like a gap up to 6 days to check the creatinine. Not sure if this one,
Did they explain why?
why,
Why the benefit? Like, did they try to explain like what they found in terms of angiography and like, was there something other than this which explained? Because the mortality benefits you are, or the hard outcome benefit you are showing is huge.
well, yeah, I would say,
Look at that.
yeah. So here we also come to different type of bias, right? For any reason why this patient have an AKI, they might be more prone to mortality events. Although the difference did seem to be significant but the AKI in itself and the dialysis would add more mortality. So preventing the AKI maybe played a factor here.
How much of these events were mortality though? Why the dialysis?
Yeah.
I mean, the absolute difference is it.
The largest is going to be myocardial infarction.
Yeah, I will have to get back to you guys on this one.
Dr. Rios, any thoughts about the dose? Like Shukla mentioned about the timing, but what about the dose and venous versus arterial?
Oh, the dose of contrast?
Yeah.
So typical dose of contrast for CT scan is 75 to 150, usually lies at 100. And for PCI is around 100 to 300 that you might use in the PCI. They do have dose of contrast reported. I just don't recall now for this study. But in general, what studies that I read through all the studies, some will, most of them will say the dose of contrast did not make a difference for AKIs.
Basically, if you have ventriculography that uses a lot of contrast, would be the same as CTI technique.
So I'm not sure if I can make a claim on the dose of contrast. They say when it's intraarterial, then it's a higher risk of AKI.
So arterial is higher than venous.
Yes, yes, for sure, yes. Well, sure.
Actually, this it says 4 days, up to 4 days.
Up to-
Yeah.
To check the creatinine again, yeah.
Because it's a 5 versus 9.5% total event difference at 180 days.
Yeah, I actually got involved in.
Have you been over here on it?
I've done a great job, but
After she comes back, consultation, and then you have to do
And they were like, "Can I play?" And nobody had time. It was the calcium. Oh.
I believe it's in
You're all ready for the weekend.
There you go. Oh, you are?
Oh.
Oh, I'm
Hit
so
the ground
sorry.
running.
Who is the co-conspirator?
Oh, really?
Yeah.
Yeah, I know, right?
Oh, okay. I just did last.
It was my point.
I would
Good times. Nothing we have in here, this is not significant. So then at this point, but then you
It's fine.
It's like, okay, so I'm gonna injure the fibrillation here, I'm out here. Finally, I. I got everything else going on. Yeah. Yeah.
We gotta come here.
They shot me. I'm like, maybe not.
She didn't go down.
Okay.
Because I'm not losing any effort, and then so they all agreed to let me continue.
Yeah.
Yeah.
Do you
How
mind
much
taking
percent
a
of
picture?
that? It was pointing out.
Have you?
Yeah, we're fine.
Yes. Send it to,
Authority
for yourself.
New grant, and then I got another one that's pending that should get funded, and maybe another 10%.
I don't
So
know,
all,
you're gonna-
it'll come out. I think.
I worked in like
But this is resolution news, you know, it's not talking.
I don't know what's going on.
Yeah, you're fine.
Done, a done deal.
You're right in front of the
I think, yeah.
X-ray.
And I have
For
pretty
some
understanding
things,
grant.
as
There you go, perfect.
productive as you have been, even if it was just like.
Yeah, 20 years, but it's
like that
just
one.
continuous, funding from that, I didn't wanna jeopardize.
Take a little closer.
Yeah.
You have it, that's great.
So, yeah, thank you, and we have those pending grants too.
I have to.
Yeah, that one.
Actually,
When do you hear about them?
You know, with the study section, we should hear, in, mid-June. But the way
Yeah.
things are now, they're delaying
Or
everything.
towards.
I can't say.
And I feel like those.
And I'm working on the budget for the
Yeah.
teaching.
That's good.
graduate
Yeah.
budget, because,
Oh, I was still asking, they don't know where, which one they're going.
Yeah.
Is it at the department level or?
it's still at the department level, but, I forgot to include the admin staff for nephrology.
Uh-huh.
You know, so I'm gonna have a little.
Give us a word a little bit about
Yeah.
the,
Yeah, so I'm gonna include that.
no, yeah.
Yeah.
Like I said, the person itself more than the timing.
Yeah.
Not the short stuff.
Exactly, but